Saw Palmetto gets sold like a quiet shortcut. Less prostate swelling, better flow, maybe even more testosterone or thicker hair. But if someone is waking up 3 times a night to pee, what is the honest first question? Does this berry extract actually change symptoms or just sound hormonally sophisticated?
That is exactly the right split. Saw Palmetto comes from Serenoa repens berries, usually concentrated into a lipid extract rather than eaten as food. The proposed active mixture includes fatty acids and plant sterols. So we're not talking about a vitamin deficiency replacement. We're talking about a botanical drug-like exposure with batches that can differ from the products tested in trials. The classic prostate story is about 5-alpha reductase, the enzyme that converts testosterone into dihydrotestosterone, or DHT. Prescription finasteride meaningfully targets that pathway. Saw Palmetto has been proposed to weakly influence similar androgen signaling, but a plausible pathway is not the same as a clinical effect. The body ladder has to climb from enzyme talk to urine flow, sleep, and quality of life.
So, if the enzyme story is biologically believable, why do clinicians keep saying the prostate evidence disappointed them? Were the trials too short? Were the products wrong? Or did Saw Palmetto just fail when it had to beat placebo on real urinary scores?
The fair reading is not that every person imagined their symptoms. Urinary symptoms fluctuate, lifestyle changes happen during studies, and placebo responses are strong when people track nighttime urination carefully. But in large controlled BPH trials, Saw Palmetto did not separate clearly enough from placebo to justify the confident claim that it treats enlarged prostate symptoms. Then we have smaller, newer studies that keep the door cracked open for narrower groups. A 2024 Japanese randomized trial in adults over 50 without diagnosed BPH or overactive bladder reported less daytime frequency bother with 320 milligrams daily. A 2022 trial in women reported improvements in daytime frequency measures. Interesting, yes. But these are not the same as proving robust treatment for male BPH.
If someone has weak stream or nighttime urination, when is it irresponsible to experiment first? What changes should send them to a clinician before they decide the issue is just an aging prostate and a supplement aisle problem?
The person most likely to notice anything is not someone with severe obstruction. It is someone with mild, stable frequency bother, no red flags, and a clinician comfortable with watchful waiting. Baseline matters because if the main issue is caffeine, evening alcohol, sleep apnea, a diuretic, diabetes, or constipation, Saw Palmetto is aiming at the wrong rung of the ladder. The bladder story is also why some non-BPH studies are interesting. Saw Palmetto has been discussed in relation to muscarinic receptors and sensory pathways involved in urgency and frequency that could theoretically change bladder signaling without shrinking a prostate. But again, the hierarchy is receptor effect, then diary change, then durable symptom relief that matters to the person.
If someone still wants a cautious trial, how picky should they be about the bottle? Does Saw Palmetto on a label mean the same thing as the extract used in studies, or can product variability make the whole experiment almost uninterpretable?
I would make it boring and measurable. Use one standardized product. Do not stack 5 new prostate supplements. And track a baseline week first. Daytime voids, nighttime awakenings, urgency episodes, and bother. Many studies use 12 weeks and 320 milligrams daily, so judging after 3 days is meaningless. If the diary is unchanged by about 3 months, the expectation should change. And it should not be framed as equal to evidence-based BPH care. Alpha blockers can relax prostate and bladder neck muscle. 5-alpha reductase inhibitors can shrink prostate volume over time in appropriate patients. Saw Palmetto has not shown that level of dependable effect. Its realistic role, if any, is an adjunctive, preference-sensitive experiment for mild symptoms, not a replacement when obstruction is progressing.
The other internet lane is hair loss. People hear DHT and assume Saw Palmetto is natural finasteride. Is the hair evidence any stronger than the prostate evidence? Or is this another case where the mechanism outruns the result?
For androgenetic alopecia, the evidence is suggestive but messy. A 2026 network meta-analysis found several supplements improved hair density measures and saw Palmetto appeared in some favorable assessments. A 2025 trial of an add-on supplement containing serenoa plus other ingredients improved response to pharmacologic treatment. That supports possible adjunct use, not proof that saw Palmetto alone reverses hair loss.
What about safety boundaries? If the product is usually described as well-tolerated, who should still mention it before surgery, before combining it with hormone-related medications, or while taking drugs where bleeding or interactions would matter?
Most trial reports describe mild adverse events, often digestive symptoms or transient complaints, and the 2026 pilot comparing salvia extract with saw Palmetto reported mild, transient events. But usually mild is not risk-free. Stop and get advice for allergic reactions, unusual bleeding, severe abdominal symptoms, or urinary worsening. And always disclose it, because undisclosed supplements are where interaction surprises happen. So the compressed answer is, saw Palmetto is a plausible botanical with weak to mixed clinical payoff. It is not a proven prostate shrinker, not a reliable BPH treatment, and not natural finasteride. If used, it fits best as a time-limited, measured experiment for mild, stable urinary bother after evaluation. The win condition is fewer meaningful symptoms on a diary, not a better story about DHT.